Testing. 1, 2, 3. Steam. Testing. 1, 2, 3. Stream.
Testing one. right, y'all ready? Shree's, he's sneaking in the back. We have a quorum present. First thing is, nobody, no people signed up to speak. And we have, the next thing is the approval of the minutes, if you all had a chance to do that.
Move approval of the minutes.
Got it? Discussion? All in favor, please say aye.
Aye.
Those opposed, same sign. Next thing is performance improvement reports. It doesn't require any action. PSI 90 update. Dr. Stevenson.
Good afternoon.
Your microphone?
My microphone is on, yes.
Okay.
Can everyone hear me? Okay, so let's go through the slides. Do I have it? I have it. There we go. So, so we will return again to our quality goal and our current results. So as we've discussed over the last several months, our quality goal is PSI 90, which is our risk-adjusted weighted measure of a variety of serious hospital-acquired conditions. Our performance continues to be fairly strong. As of a couple of days ago, this was our result. We're still well within goal being better than 1. And if you all recall, 1 means that we are performing as expected for the types of patients that we take care of on all of these different measures. So as of 2 days ago, we were 0.92 for the year. But I will tell you that this is a bit of a dynamic measure, or at least the process of getting to the measure is a bit of a dynamic process. And we actually have a couple of different computer programs that actually scan our medical record to identify cases that we then have to review to see whether or not they would meet. So in the initial look at this data, we had 4 cases for the month of July, which gave us that month score of 0.98. Unfortunately, the other program said that there were 5, so we had to spend some time working between the 2 programs to figure out which was correct and also to look at the case to see whether or not it would meet. And indeed, in final analysis, it did meet, but we only determined that a couple of days ago. So the actual number for July will actually be 1.14. So it's actually the first month where we have had more events than we would have anticipated since we identified basically the coding opportunities to improve this measure from the first quarter. So this is not necessarily a surprise because these events are uncommon, and the reason that groups like Leapfrog, for example, look at measures like PSIs over an 18-month or 2-year period is that they're that they're rare enough that to get a meaningful number, you do need to look over a fairly lengthy period of time. So to have 1 month that's a little bit above the line is about as surprising as having a month like April where we're massively below the line. There's going to be a significant amount of month-to-month variation, but what will be much more meaningful is when we have a 1-year number and then even more importantly a 2-year number to really see whether we're really succeeding. But I think on the whole we're definitely moving in the right direction. I think I'm hopeful that August will be back down again, but it was just one of those months. The next page just gives you a sense of where we stand. The one thing that changed was that we had one more postoperative sepsis, so I'm going to give you the next slide. So if you look at postoperative sepsis here, it was 3.93. With that additional postoperative sepsis, it's 4.72. And with this information, we've been keeping our eye on this postoperative sepsis issue for the entire year. Again, it's a very highly rated measure. And the sepsis individually are fairly rare, but I think now that we're pushing up even higher than we had anticipated and significantly higher than last year, I think this is now time, and we're going to charge the Quality Council to start digging deeply into the postoperative sepsis issue and seeing where our opportunities for improvement lie. So this is, again, really why we are looking at PSI 90 and other similar type measures, is to look at areas where we are not performing where we would anticipate performing as an organization, and targeting those things for improvement activities. Conversely, DVT and PE, which still remains significantly elevated, for which we do have an improvement program in place, that's a much lower weighted event in terms of harm than the sepsis, and there are a lot more events that are in that PSI 13 measure. So we were already pretty sure, just based on the fact that that represents a significant number of events, that was something that we need to look at. But now that we're getting on into the year and sepsis is still remaining out there as something where we're just not performing like we would like to perform, now it's time to take some action on that one.
Is it just surgery in general?
No. So there are some complexities here. So to say postoperative sepsis, one of the challenges that we've had is that, for example, bronchoscopy counts as surgery. Now that's actually changing October 1st, and let me lay it out a little broader. Okay, so endoscopy has never been an operation, but for some reason bronchoscopy is. It's a weirdness, and it does hit teaching hospitals a little bit harder than it does non-teaching hospitals, and it's a weirdness. So if you get admitted to All Saints, for example, and you've got gook in your respiratory tract and you're on the ventilator, somebody's going to order the nurse to do endotracheal suctioning. In a teaching hospital, we are much more likely to do bronchoscopy because it's probably a little bit more effective. It takes a little bit more time, but there's there's great educational value in teaching bronchoscopy in that way. So it's sort of like a win-win-win. You get a better suctioning than you would by just blindly sticking a catheter down the endotracheal tube, and you also you can see what's really going on down there, which is nice as well. And then thirdly, you get to teach trainees how to perform good bronchoscopy. So it really is an excellent thing to do, and widely teaching hospitals, whether you're talking about Johns Hopkins or John Peter Smith, perform a lot more ICU and bronchoscopy than we do. But it puts a lot of patients.
Attention please, code red, Trinity Springs dining room. Attention please, code red, Trinity Springs dining room. Attention please, code red, Trinity Springs dining room.
So anyway, it puts a lot more patients into the surgical category, in our teaching hospitals, and I'm sure that that teaching hospital upset about this issue is probably one of the things that has gotten this changed. Is my suspicion. So, all right, questions about our PSI 90 results? Okay. So the second part of my presentation is to, is there more? Where's the rest of the slides? Well, I hate to go through things without the slides.
Can we get them?
Can we get them over there immediately?
We can take a small delay.
Anything else you want to ask me while we're waiting?
Hochberg's back there grinning. I mean, he's up to no good.
My team up there. Make sure we got everything prepared.
I know, right?
Speaking of your team, I saw a picture of you. I'll have to.
This is open.
this works, but we'll get it.
You got it? It's sent?
I do have a question for you, though. With the new rule about how we can interact with the staff of the network, didn't Neil tell us that we weren't allowed to have these one-on-one conversations and because I wondered after we met, did I break one of the rules? I met with Michael, Michael was on the phone, but I met with Rob to discuss the agenda mainly, but we went over the material. Is that okay? Now, I don't know.
I'll follow up with Neil. I was not a part of his conversation with you, but I'll certainly follow up. I think, that,
Yeah,
obviously we want to comply with the Open Meetings Act, so
Do we have it now?
I'll find out.
Yeah,
Okay.
it didn't dawn on me till after I'd done it, and then I thought,
I think when we were talking to Neil, we
Okay.
made it clear that it didn't make sense.
Thank you.
That we couldn't talk. And I think the open record was if we were talking, they wasn't making a recommendation. It wasn't like it was a meeting. So I disagreed with his recommendation.
well, I had a brief conversation with Robert. Mr. Browder, he was just kind enough to be available, and I asked him if it was okay, and you did the right thing. You referred me to Neil. But number two, you said that nobody wants to be the test case to I guess, get the Attorney General's opinion. Why would you not want to be the test case? Is it?
There's an unknown, sir.
Oh. But God knows the law's an unknown. I didn't say that. Okay, go on. I'm sorry.
Very good. It's been precisely 5 months since Dr. Hochberg became the Chief Clinical Officer and I assumed the role of interim Chief Quality Officer. And so, especially given that it's to the day anniversary, it seemed like a good time to sort of review what we've been doing and sort of give you a sense of, we've talked a little bit about the perspective that Michael and I have been bringing to the quality effort at JPS, and to sort of flesh that out for you a little bit and show you, just give you a very high-level overview of some of the stuff that we're working on. So, as mentioned, on April 5th, Dr. Hochberg and I assumed our current roles. And so why do we want to do this now? Well, again, to lay out why we're doing what we're doing and what it is that we're doing because of that why. So our basic tenet and approach is to create and encourage a proactive, open environment, asking questions of why and how, so why things are happening and how they're happening, while building upon our previous successes. And of course, the past, and one great example of the past laying the foundation for our evolution forward, is that the PSI 90 goal, which has been very instrumental in driving things forward, like what I anticipate to be future leapfrog performance, really does lay the foundation for our evolution forward as an organization. So this new role, these new roles for both of us have been an opportunity to assess, evaluate, and re-engage quality and safety at JPS generally. So I think I mentioned in this forum earlier on in my tenure what I think the best definition of quality healthcare is. And for me, it really is the guiding light, if you will, for everything that I'm trying to accomplish and that Michael and I are trying to accomplish together. So quality healthcare is the healthcare that one expects their own family to receive without requiring special arrangements to be made. And so that means instead of hey, I'll call my friend at so-and-so and they'll take good care of you. It's go to our emergency department, you'll get great care. Have surgery.
Attention please, code red, all clear, Trinity Springs dining room. Attention please, code red, all clear, Trinity Springs dining room. Attention please, code red, all clear, Trinity Springs dining room.
So were they serving some type of flaming meal over there? I know Azealia just ran out. Maybe.
I'm back. It was
Oh,
a
okay.
drill. It was a drill.
All right.
Okay.
Sorry.
So, have surgery in our place, you'll get great care. Go to our clinic, you'll get great care. Be a patient in our hospital, you'll get great care. And you don't have to call your friend who's the chief of, medicine or, put together your own ICU team or anything like that. You're just going to get cared. Of course, there is no hospital in the United States or probably anywhere that can live up to that every single time, but it needs to always be there in our minds of what it is that we're trying to achieve, where the vulnerabilities have been dealt with, where our patient experience is outstanding, where our systems of care are phenomenal, so that we really don't have to worry. We can just send our friend or family member over and just know that it's going to be a great experience and that they're going to have great quality health care. So what are the big picture ways in which we want to accomplish this? Well, number one is really a relentless pursuit of our vulnerabilities, regardless of source or area. So anywhere where we identify gaps in our processes or in the execution of processes, we want to shore that up everywhere we can find it. Reducing variation is a major key element of improving the quality of healthcare. When we have great variability, it becomes difficult for groups to work in teams because people don't know they don't know the script, they don't know where they're going, and they have to try to make things up in a one-off way, and that kind of variability leads to gaps and difficulties. And one big area that I've been very interested in since I got into this role was to take the various things that regulatory agencies and others ask us to do, take them to heart, and to use those things to become the kind of organization that they want us to become. CMS, AHRQ, Leapfrog, Joint Commission, they want us to be a particular kind of place, and it's a kind of place that delivers phenomenal health care every single time. What frequently happens, and what a lot of organizations get into, because there's a lot of stakes behind these things, is that they want to make the measure look good, they want to make the survey look good, and all that sort of thing, but they haven't actually embraced the ask, the true ask, and consequently they end up building sort of Potemkin villages, if you will, where everything looks pretty as they walk past, but it's hollow, it's not real. And so what we want to become is the place where that is real, okay? And then partnerships, between providers and nursing, between support services and others, between executives and frontline staff to make all of these things happen. So our tactics. The first was really to revamp the Quality and Patient Safety Division, and I'll show you our current upper level org chart, which will give you a sense of what our priorities are. Retool some of the key committees around the hospital, particularly patient safety and quality councils, which we've discussed in previous meetings, but others as well, and I'll show you a couple of the others that we're looking at. Increase ongoing physician, staff, and executive engagement in quality, safety, and accreditation efforts. So, when I first started going to root cause analysis meetings a few years ago, there would be maybe, a director level person there, maybe one other physician, usually a bunch of nurses, and everybody worked really hard and wanted to get good results. But Now what we have every time are a collection of some of the most senior executives in the hospital, not only physicians and nurses who were involved, but also their leaders, and also very often the service line chiefs of the service lines where the providers who were involved in whatever the event was. And the beauty of this is that it creates, when we identify something, it immediately can generalize out to the whole organization, because you have people with broad vision and broad scope in their work immediately there at the table, looking at the action plans and making sure that they're going to have that kind of broad impact. And I think you've seen some of that in some of the action plans that we presented. And then, to sort of follow on from that, to use some of these specific cases to identify broader organizational vulnerabilities. For example, do we do handovers well, this kind of thing, to address, to stimulate broad change efforts that will actually have impact across the organization generally. Another major focus, and you've seen this and we've just discussed it in the context of PSI 90 and postoperative sepsis, that we are now very actively using quality and safety data to order our change priorities, to decide what's most important. And now out of that particular measure, you can see that we've chosen DVT and PE prevention, and now probably addressing postoperative sepsis as areas where quality data has actually driven us to address particular items. And then using, again, back to the taking to heart what these organizations are asking us to do, to use regulatory standards and other required reporting measures to stimulate broad positive forward momentum for the organization, taking those things to heart. So this is our current org chart, redesigned org chart for the quality division. As interim chief quality officer, I report to Dr. Hochberg as chief clinical officer. I'm supported ably by Sean Shelton, way over to my right. We have named a new executive director for quality operations and implementation. That's Emily Gard, who should be starting on September the 30th. She's a very experienced and dynamic healthcare leader, deep background in quality, passion for quality, currently serving as system chief nursing officer for Life Care. With the dissolving of Life Care, which is about to happen at the end of this month, she was available to us. Sri Adisamili, who's our Director of Clinical Quality, is remaining with us, and he is responsible for delivering the data on the PSI 90, so you have him to thank for that effort, as well as many, many other reporting requirements that he and his team take care of. Adele Cunningham is remaining in the position of the Director of Patient Safety and Regulatory Affairs. So she's responsible for the entire patient safety effort, and it's out of her group that the root cause analyses are performed, and that overall events are looked at, and so that remains a very, very high impact team. I'm going to skip over to one other person who's basically in place, which is our new Director of Performance Excellence. Jessie Thomas was recently promoted from the Manager of Patient Risk into this position. She's an experienced Lean Six Sigma black belt, highly passionate about healthcare and quality, and will be a huge impact player for us. Starting on Monday of next week is our brand new permanent Director of Infection Prevention, Chantal Besa. She's a fascinating person with an incredible background, originally a Congolese-trained physician, also worked later in her career as a nurse in France, so she's been on both sides of that line. Interestingly, she's worked for both Médecins Sans Frontières as well as for the CDC, and she's coming to us from another hospital in the area where she's serving as manager of infection prevention. Highly effective person, and we are very excited that she's going to be starting with us on Monday next week. In the middle is a new position, which is the Director of Environment of Care and Life Safety. So this position replaces the previous Director of District Safety, which was very much a fire prevention focused role. This is a much broader role that actually I designed in collaboration with Kenny Carr and Gary Scott from Support Services and Clinical Engineering. And the goal of this position really is to fully understand all of the regulatory requirements that are involved with all of the non-clinical activities of this organization, and to engage with those teams to provide performance improvement assistance for all these non-clinical areas. And these are really they're really the biggest parts of the TJC book. And so the goal here really is to have an individual who will passionately drive us towards an environment where we have an environment that is absolutely safe for our patients to receive care, for our visitors and families to visit, for our employees and others to work. We have identified a phenomenal individual who's coming to us from the THR system, Melissa Kyle, who is a certified health safety professional, certified health system construction professional, certified health system manager, and a certified healthcare emergency management professional. So, phenomenally well-qualified individual and a dynamic personality to boot. So we are really excited, and she's coming next month. So we've talked before in this committee, and I thought it would be important to revisit again sort of the buckets of items where we see when we look and identify our various vulnerabilities, where they lie. And there are really 6. One are things that come up in situational communication. So we don't communicate in the context of a healthcare situation in a way that is as effective as it should be. So that's one area of potential vulnerability. One is, if there is a situation, does it get escalated to the people who can actually affect the right outcome? Do we transition care from one person to another in a way in which is as effective as it should be? And does that happen all the time? Are our clinical processes tight? In other words, have we designed things where our team members are set up for success, or where they're set up to struggle to succeed? If we have a good process, do we hold ourselves accountable to follow it? So do we allow deviation away from whatever the process is that we've designed? And finally, have we made sure that everybody involved in the situation, has what they need to execute it appropriately? So have we established our competencies, or have we helped provide training to make sure that people are competent in everything that they're doing? Do they know the clinical processes, for example? So that would be an example of an issue of competency. So we have reformed a variety of committees, or in the process of reforming a variety of committees. We've talked about Quality and Safety Council. So just to remind the group, Quality Council's job is to review our quality data and to identify priorities for quality improvement efforts, and then to launch work groups to address those priorities, and then to get feedback from those work groups to make sure that we're actually delivering on those quality improvement efforts. Patient Safety Council kind of similarly takes a look at events and asks, are there things that we need to be, reviews our action plans from the root cause analyses from serious safety events and sentinel events, and looks to see whether or not there needs to be initiatives done out of those action plans that could be best coordinated by a high-level committee like Patient Safety Council, and then once again launches work groups to begin to address those things. In the same measure, we're actually retooling Pharmacy and Therapeutics Committee to a significant degree to sort of adjust the membership, as well as its focus to make it more focused on issues of quality and value for our organization, to make sure that the things that we're bringing into the organization from the standpoint of therapeutics in general are things that are going to help our patients have better health, and hopefully at also with a strong assessment of value as well. And then moderate sedation committee, we're in the process of retooling that as well to make sure that we are really identifying all the events that happen there and make sure that our processes around moderate sedation are tight. We've also formed a new high-risk surgery committee. This is one of those things where somebody on the outside has asked us to do something. So in this case, Leapfrog thinks it's a really good idea for us to have appropriateness criteria for certain major surgical procedures like mitral valve replacement, carotid endarterectomy, open aortic procedures, and thinks that patients who are having big cancer operations like pancreas or esophagus or rectum or lung are being discussed at a multidisciplinary committee, which is very appropriate. So our high-risk surgery committee is tasked with two things. One is to make sure that when those kinds of procedures have happened, that they followed the appropriate risk criteria, and then feedback to the surgeon to say, hey, you know, actually this didn't quite meet, you know, what's going on here. And then the second is, and then part B of that is to make sure that our, you know, patients who are going to have pancreatic duodenectomy for Whipple, for pancreatic cancer or a major lung resection, you know, that those cases have been discussed in a multidisciplinary committee, which we have as well in multidisciplinary tumor board. And then the second is that when a surgeon or referring physician you know, has a patient who, you know, is by a variety of risk assessment tools, and we have the NISQIP one here in active use, when the risk of a particular procedure appears to be high, to have a forum, to have almost an ethics committee type discussion about whether or not that case should go forward from a medical standpoint. Not so much from an ethical standpoint, but to review everything to help the surgeon deal with the risk-benefit analysis and give the surgeon guidance as to whether or not to proceed. And that obviously is not true for hyper-emergency conditions, but if you've got somebody who's got, you know, very bad COPD and heart disease, and you know, we're trying to decide whether they should have a hip replacement or something, it's a great place to have that discussion where you can see whether the risk-benefit tilts in favor of or against doing something. And it provides the surgeon, you know, some backing as well if they're getting pressure from families or referring physicians to say, you know, really, we've discussed this in a multidisciplinary format, and really the judgment is that it's not appropriate to proceed. Or conversely, no, it looked okay, you can go ahead. And then you've had a discussion, and so if the patient has issues post-operatively, you can say, you know, well, we talked about it, A. And B, the other thing is that in this committee we have pulmonary and cardiology, and so if we decide we go ahead, we've already got buy-in from those specialties to help us manage the patients so that we can try to get them the best outcome they possibly can have.
Good.
So, you know, so as we go ahead, as we've gone forward and looked at our vulnerabilities, we've identified a whole series. You know, we've gotten into just an incredible number of projects, which are all either done or well underway to try to deal with these vulnerabilities. And some of these you probably heard about, like how we've improved our processes for high suicide risk patients in the ED. We're working on basically a way of dealing with patients with acute behavioral health issues now on the inpatient side, because the work on the ED sort of focused us on the issue in general for the hospital. So we're in the middle of getting meetings together to discuss going forward with what is really best practice in terms of dealing with behavioral health in the ED. Agitation order set is part of that as well, which has been huge, which the behavioral health group has really helped the organization with, but Qualtiy has a hand in it. Talking about ways of improving our phlebotomy methods in high acuity care, improving ED throughput, escalation in labor and delivery, high flow insufflation for laparoscopy, RF sponges, MRI safety, pre-procedural huddles. So this is an expansion of the perioperative huddle to other procedural situations. We have a task force on handoff and handover, another task force on peri-procedural anticoagulation management. We're looking at retooling endoscopy completely, improving care for patients who are NPO in terms of better signage and explanation so patients' families know what the patient's supposed to be doing, making safety call better. That's a very active piece of work this week especially.
What is that exactly?
What's safety call? So every day, almost every department of this hospital has to report in to the whole group on a very large conference call to talk about safety issues going on in their areas. And so I would say that its first benefit was and it's been going on now for about a year and a half. Laura Burnside was sort of the original energy behind the project and remains very, very connected to the safety call. I think, it was absolutely an amazing tool, I think, when it was first introduced, in terms of just bringing the whole hospital together for the first time on a daily basis, so everybody feels together. And a lot of the information on the call is pretty useful, but some of the information we've kind of sorted out maybe isn't so useful. It's kind of rote and repetitive, so we're just looking at ways to kind of energize it a little bit more and make it a very, very high impact call. And the other thing we've done is, as of this coming weekend, it's going to be 7 days a week. So it's been Monday to Friday since its inception, and now it'll be 7 days a week because, of course, quality and safety are an everyday job. So, and then we've been working on high-level disinfection as well, which is, of course, an area of national interest. Regarding quality measures, we have obviously a continuous examination of falls, and actually falls data has been improving over the course of the year thanks to these efforts, but we're also looking at whether new beds may be able to reduce falls, and there's some evidence to believe that that is true. As those of you who've been on the committee for a little while know, we've been looking at colon SSI for a while. This has stimulated changes in perioperative blood glucose management, as well as an enhanced recovery after surgery program for colon surgery. Those things have both been pretty successful, and for the first time, our SIR, which is the ratio of observed to expected for our colon surgery population, has gone under 2 for the first time. So even though it fell off the goals, it's been an area of continuous look, and getting under 2 is not insignificant for a hospital like ours. You say, well, that still means we're at 1.69, you're 69% above expected. Well, yes, but we do have some challenges, and the challenge is that when you look at our 225 to 250 colon operations we do each year here, only about 93 are done on outpatients coming in for elective colon surgery. So we do have, we are highly enriched in colon surgery coming out of the emergency department, and those patients are higher risk. So it's going to be tough for us to get under 1, but I am very pleased that we are definitely moving in the right direction. Hysterectomy SSI has been an amazing story. With the addition of metronidazole and getting buy-in from all the gynecologists on hysterectomy perioperative prophylaxis, that harm event has essentially disappeared since it has disappeared. We have not seen hysterectomy SSI since last fall, at least not one that's organ-space. So that's really a remarkable accomplishment. Based on some data we've seen in our total joint program, we've taken a whole new look at OR cleaning and preventative maintenance for HVAC. We're looking at sort of the right approaches for bathing and pericare under Qualtiy.
What's HVAC?
Oh, sorry, heating, ventilation, and air conditioning.
Okay.
So, but Kenny and Gary have this guy named, director named Omar, who is a absolute master of HVAC. and he is retooling everything. Under CLABSI, there are a bunch of things going on to try to further reduce central line infections, and actually our results in that remain fairly good, but could be better. So we've discovered that a lot of these infections are happening in patients with dialysis catheters who've had them for a long time. So we're in the process of launching a peritoneal dialysis program, and we're also trying to increase the number of patients who get sooner to surgical hemodialysis access. And in addition to that, we're improving hemodialysis catheter care by kind of focusing that in the dialysis unit, and we now have the right bio patches and all that stuff, so we're really hoping to see some movement there.
Good.
And as I've mentioned before, we've got a work task force going on in DVT and PE mitigation, risk stratification and standardization. Some of our priority initiatives under Leapfrog, and you're going to hear, this is an advertisement for November, but we'll be coming to you in November with data and action plans around hand hygiene. At one level, the data looks really, really good on hand hygiene, so it's been an area of focus here for some time. But Leapfrog actually asks us to bring this data to the board and our action plans. And, in the spirit of taking this to heart, why do they ask us to do this? Because there is absolutely nothing that we can do that is more important in infection prevention in a healthcare setting than having outstanding hand hygiene. There is nothing more important, and this is known by the Leapfrog people, so they want to see us take it seriously and bring it to your attention, exactly what we're doing about these things. Similarly, in the spring, we conducted the Leapfrog required AHRQ culture of patient safety survey, and it is and just like the hand hygiene, they want us to have high-level buy-in at an executive level around the results of this survey, to design processes that will improve the culture of safety, and then bring it to you to show you, so that you can have oversight over what we're doing in this regard. Why does this matter? Why does this survey matter? Well, there was a really nice paper in the Journal of the American College of Surgeons actually in the last month, which showed that hospitals with higher scores on this particular survey have fewer surgical complications. So there's actually this is now a very clearly demonstrated relationship between our results in this area and our outcomes for our patients. So it's critical that we take the results of this survey seriously and look at ways to improve. And if we do, it's going to be better for our patients, so we've got to do it. And again, this is something that the Leapfrog people know, and so they want to see us take it seriously, so they want the executives to be involved, and they want our board to also be aware of what we're doing and approve of what we're doing. And then, as well, I mentioned this the high-risk surgery committee earlier. And then in terms of our regulatory compliance and how we're trying to drive that forward, well, this is the motivation for having created the position of Director of Environmental Care and Life Safety, so that we have in-house the expertise we need to try to make this environment the right environment for our patients, families, and employees. So that's the end of my presentation. If any of you have any questions, I'd be happy to entertain them.
You can start all over again.
You've got a lot of work going on.
It's a big hospital. It's a big health network. We got a lot to do.
Yeah. No, I look forward to seeing the evolution and the outcomes, for sure.
When
Dorothy, go ahead.
When you're looking at the colon SSI, and you're saying a lot of them are coming through the emergency room. Are any of those our JPS connection that's been in our program and just have not been?
So the answer would be yes, some of them would be. Our penetration of screening is not what we would like to see, certainly. They're not all cancers, though. I mean, some of them have diverticular strictures. Some of them have, you know, once they get perforated or something, they're not really going to fall into the SSI category. But you know, one of the cases I can think of right off the top of my head was a patient who came in with a diverticular stricture and got surgery and subsequently got an infection. So, you know, operating on obstructed colons, even if they're not perforated, you can't prep them. Because that would be, you know, a certain form of torture. So, you know, you're going to be at a higher risk for getting an infection under those circumstances. So whenever you have a population that's enriched in what's coming through the ED, you can't do everything that you would do for somebody coming from home where you have, you know, prepped the bowel, you've optimized them in terms of their comorbid conditions like diabetes, smoking, all those things we've gotten very serious about through our surgical optimization program. So that group of 90-something, they can all go through that and be made as perfect as possible. But when somebody comes in with some issue that needs to be managed in an urgent way surgically, your options are a lot more limited in terms of mitigating those risks.
Okay.
I don't look at it from prep versus unprep.
No.
It's all just
It's
the same thing.
it's the only thing that gets that excludes you is if there is infection present at the time of surgery. So if you operate on a perforated colon and there's stool and pus everywhere, that patient isn't going to be counted in the CMS reported number. But if, you know, they just happen to be obstructed but not perforated, then they're still at higher risk, but they don't get excluded.
Okay.
So.
Would there be any value just internally looking at both emergent and non-emergent and to see where we fall from a non-emergent?
So we have very, very few infections in patients like, I don't know if we've had one this year in a patient who came in from home. So our program on the elective side is very, very robust. So we might have had one. I wouldn't want to be absolutely held to that, but it's very low, yes.
How's it working from your standpoint, Brian?
So we're starting to use a
Total
lot of
joint.
the same program that, we're starting to use a lot of the same program that they've done for the colons to go through with our total joint program. And we've hired a nurse practitioner that's working on all of our patients to get them preoperatively medically managed and go through the optimization clinic here at the hospital. So a lot of the great successes they've had, we're starting to take over to the orthopedic side.
And they also have a fantastic joint class that all the patients are required to go through, so they're really well educated about their process. And it's a strong program, and I think we're beginning to see some good results from it. So.
That's a pre-op program?
Pre-op.
Awesome. No, a lot of good things going on. Many good things. Is the leapfrog data that we report to them, are we still about a year and a half, year behind?
So it's,
Am I asking the question properly?
so it's complicated. Most of those, you know, lagging metrics are actually pulled metrics. So it's not stuff that we report. It's stuff that actually comes out of our coding data that they're pulling, that CMS is pulling out of us, and then Leapfrog uses that CMS data. Okay. But it depends on the measures. A big chunk of Leapfrog is about stuff that we're doing, and that we have to tell them whether we're doing or not. And if they come and audit us, we better have been doing it. So, you know, so there's a lot of accountability around that. So that's stuff like whether or not we're presenting our hand hygiene stuff to you. So that there's a big category of stuff that's that. Then there are some things that then there's a bunch of stuff that's pulled metrics. Like, for example, our results on HCAP surveys. So you know, we're doing it, but that data is being pulled up by CMS. They're looking at it and then they're reporting it. That stuff isn't that delayed. That's maybe 6 months to a year, at most a year and a half behind. So, you know, if you're doing your fall survey, you're probably looking at 2018 data. So fall of 19 survey would be probably 2018 data. And then for these PSIs, which are much less common, so if somebody, we were talking about postoperative respiratory failure, postoperative sepsis, especially those two, but all of them are sort of lumped into this, then we're looking at data that is roughly 12 months old to roughly, 36 months old, something like that. Or 27 months old, or something in that range, 30 months old. They wait for a period of time to make sure that what they're collecting is accurate, and then they report a fairly long interval to make sure that the little bumps of the incidence of these things, because they're relatively uncommon, get kind of smoothed out by a fairly long time interval. There are a variety of different time frames, but I mean, I think the most important way to think about leapfrog is that to really perform well on it, it requires sustained effort. So you can't just give a 6-month effort and expect your score to move very much. It's got to be something you're really on year after year after year after year.
The leapfrog score was one of our measures, and I assume it will be one for the future as well. You mentioned how hand washing is so critical, and I agree. But I'm going to call on Reverend Ralph Waldo Emerson here to tell a little story that he told the whole board about hand washing. You remember? You were visiting one of your people in the hospital. Tell one little deviation. It's going to run into a room without washing your hands.
Exactly right. Well, if you'll forgive me a very bad analogy, but I like to, this is how I teach hand hygiene to my residents.
Is this going to terrify me?
No.
Oh, okay.
Might terrify the legal counsel, however, but not in any bad way. But the way I teach hand hygiene is that to my surgical residents is that I say, you know, so let's say you did surgery on a patient a couple of weeks ago. You did some sort of open abdominal surgery, and they come back a couple of weeks later with abdominal pain, and somebody gets an X-ray, and they put up the X-ray, and there's this big white thing sitting in the middle of the abdomen. And I said, what is that in the abdomen? Sir, that sounds like a malleable retractor, sir. I'm like, yeah, that's what that would be. Is that a bad thing to have happen? That's a very bad thing to have happen, sir, yes. Okay. Is there likely, is that going to get people in trouble? Yeah, it's going to get people in trouble, okay. And I say to them, so that bothers you a lot, right? And they said, yes. But I said, is anybody likely to die from that? And the answer is no. You just have surgery and take it out. Like, okay. But it bothers us because we can see it very clearly with our eyes. It's very bothersome to see when we see that. And, but it's not, it's a bad thing, but it's not dangerous in the way that some other things are. I said, well, okay, so what if you go from patient A to patient B and you don't wash your hands? Now, you can't see anything on an X-ray about what you took from patient A to patient B. But can somebody die because you did that? Absolutely. So every single time you need to wash your hands. Every single time. And that's how that's my extreme way of teaching it, so I beg the board's, the committee's indulgence for that, so.
That's good. Did it terrify you?
No, sir.
It would have terrified you if you were a defense counsel for the, for the surgeon.
All righty. Any other questions, comments for Rob? Amanda, any? All righty. Good.
Okay,
Good work.
thank you, sir.
That is all that I have for open session. We have a little bit to discuss in closed session. We could take about a 5-minute break. We'll reconvene in executive session pursuant to Chapter 551 Texas Government Code. 201.
Planning Committee meeting. We do have a quorum, and so we're going to get started. I do not anticipate us being here a long time today. And just for the record, my son has his first seventh grade football game at 5:30 this
All right.
afternoon, and I plan on being there.
Okay, well, let's,
Mr. Chairman, you're going to have to step up.
Well, you need to move on then, is what I need to say, Mr. Purdy.
All right, so I'm
If not, he's
informed
going
of
down to
no
the vice
citizens
chair.
wishing to appear before the committee, so we will move straight into our matters of deliberation. I'd like to get a motion on our minutes from the July 18th meeting, if I could, please.
Move for a second.
Motion from Dr. Weber, second from Mr. Powell. Any question or discussion? All in favor say aye.
Aye.
All opposed, same sign. That motion carries. Thank you.
okay.
Angie, where are you at? Hello there, come on up. While you're walking up, let me give you all kind of an overview of the agenda today, and Ralph's not back in here, but I'm sure he will be directly. We're going to go through our typical capital project report and get Angie to keep us updated on that. The second item on the agenda was requested that we add this item. We're going to have a discussion about the prioritization process in the bond package, and specifically, I've asked staff to walk us through exactly where we are in reference to existing contracts and where we plan to be in terms of future discussions relative to the board's decision and the board's recommendation on priorities. And I want to keep that as a kind of a global discussion. I think most of you are aware we are having a joint board meeting with the County Commissioners Court on the 17th, and I'm confident this topic will be deliberated extensively during that meeting.
And Mr. Chairman, it's my understanding that is a posted joint meeting. It will be also a public meeting for,
Good. So, anything that we do here today, I think we're just going to consider supplemental information, make sure that we've got the right understanding from staff about the process and where we are now. But relative to any action items, I think we'll just we'll defer that until after we've had our meeting on the 17th. And if the chairman directs us to meet again beyond that, then we will do so.
Okay.
So, Angie, welcome. If you'll walk us through the capital projects, we'd appreciate it.
Like that on green. Okay, so for our first one, our ED expansion into the shell space over on the pavilion, the east side of the street, we are excited that that's going to open on schedule on October 1st. That gives us 12 new treatment rooms, and we've got 14 chairs in there, so about 26 spaces, so that's really exciting for our ED. The radiology equipment project, that was lots of general x-rays, and our last thing was that third MRI, so we're on track to get that finished. We're confirming with the state that they're going to come do their final inspection on or around October 7th, and so we'll open shortly after that. And our last one is the evergreen, never-ending behavioral health environmental safety project. So we're still in the midst of that. Our two biggest pieces that are left are the Trinity Springs dining area and the courtyard. So originally, we didn't think we were going to have to do anything to those, but they've come back and said, yeah, ligature resistant, even though somebody, staff's there all the time, we're still going to have to do that. So we're looking at getting that finished this year.
Does that push our schedule?
Oh, it does.
A little
It does
bit.
push it, because we didn't originally intend to do that, because the state was accepting mitigation plans originally, and those are always staffed.
Sure.
And that was our mitigation plan, but now we're going to have to go ahead and go in there and do some work.
Okay. How much you think it pushes it schedule-wise?
Oh, at least probably a good 6 to 9 months.
Oh, wow.
Yeah.
Okay.
I mean, it just is. There's,
Yeah.
if you look at the courtyard, there's lots of trees,
Sure.
there's a wrought iron fence,
Sure.
there's just a lot of things we're gonna have to take care of out there.
Okay.
And in the dining room, it's mostly the tray line that goes through there.
Is it just state stuff that we're having to permit and worry about? Are we pretty good on entitlements regarding the city and all that?
Everything else is fine.
Okay.
We have good luck with the city, no
Good.
problems at all.
Yeah, they are great helpers to us. We appreciate that very much. Okay, anything else on capital?
No, that's my
project?
3 capital projects going on right now.
Roger?
And the radiology equipment, construction is about 40 grand over budget. Did we know about that, and what is it?
Let me look at that. You know what, on that particular project, we got a deductive change order from our contractor. It was around 52,000, so that's gonna come back down.
Oh, okay, all right,
So thank you for recognizing that and asking.
That's a true city council member right there. Good answer too, by the way. That's
Yes.
good news, good news. All right, any other questions for Angie? All right, good. So let's, and Reverend Emerson, you were away when we started, but I've kind of encapsulated this in a way to frame it. we, as you know, have a joint county commissioners board meeting on the 17th. This is basically the agenda topic for that as well. You had asked at our last board meeting to revisit this item on the planning committee, so we put this on today to do that. I've tried to get the staff sort of prepared to make sure that the planning committee understands the process that we have been through to date relative to anything that would be bond affiliated. And also make sure that we understand process.
Right.
Because I think there may be some miscommunication about some of the process relative to who we've retained, what their scope is, what we still have to do with regard to competitive bidding and all that. So I want to first give you the floor and let you frame your questions and observations however you want, so that we don't miss something today. But and that goes for everybody else as well. But then following that, I'd like to get staff's sort of response to it, and we can kind of have a discussion and walk through that in a manner that hopefully clears it up for us.
Well, first thing is that I'm the one who made the motion to go forward with the 2 medical homes.
Sure.
Okay. But after that, I got a lot of questions about, hey, are we handpicking who we are going to do the plans, who are going to do the construction? How do we determine that we're going to do 2 medical homes when we talked about behavioral health and we talked about the patient tower? So it made me come back and say, whoa, you know, I mean, because I kept getting a lot of questions on that.
Sure.
And especially, I don't know about anybody else, because I have a consulting firm and a contractor at my doorstep almost every day.
Yes, sir.
You know, so I thought I'd come back and say, hey, can we take a look at that? Then the other side of that is, what concerns me is, I'm gonna beat on Charlie for a second. But seeing that we don't have any long-range plan, we have not talked about where we're headed in the next 5, 10, 15 years. And so we're going to put 2 medical homes out there, and we really haven't talked as a board if that's really our priority or where the medical homes would go. And so I was uncomfortable that we have not had any board retreat, no sessions to really talk about what's on the horizon, okay? And then we look at going into the bond program, you would just think that we would get a firm in here to really do a program budget, help us program how to just put it all together, just to implement the whole process, the bond. And so that's kind of where I was with the situation.
Yes, sir. That makes sense.
Hey, Mr. Chair, if I could.
Yes, sir.
Update, and Ralph and I, we talked about this. Chuck serves on the executive committee. We met last week, working on the agenda for the 12th, which is next board meeting. We are going to be coming back because, I know, Amanda, we've had some questions about, you know, we've got to have a 5-year plan that we worked last year, obviously trying to get the bond thing passed, and now where we're going. And Robert's in the process of coming up with, we talked about some companies, so we're going to come back to the board fairly quickly. We also have officers nominations, and we got an election coming up, and we thought as that changes and that baton passes, that there'd be a group on board to start with that and go forward. So we've heard that very loud and clear, so you're right on, Ralph.
Okay. So, Ralph, let me ask you then if this is an appropriate way to sort of get answers to your questions. What I'd like staff to do is take us through, there's basically 4 components that we've talked about at the board level that would be recommendations to the Commissioners Court regarding proceeding with items in the bond campaign. Those are the 2 medical homes, the ambulatory surgery center, which I am naming incorrectly now. What's the new name of that? There you go. Patient Care Center. Old dogs just don't learn new tricks. The psych emergency center, right, and the parking garage. And those were the things that we had sort of listed as being potential first projects. And just to recap for a moment how those projects came to be, there's been a lot of discussion about how long it's taken to really get things moving after the bond election. Part of that, as you all know, was we had a legislature that was running amok. We had no idea what may happen or may not happen regarding hospital funding. Once that was finished and we had a picture of that in May, then I think there was a lot more energy applied to trying to come up with at least an initial solution. Some of the parameters with that were, what is the cost of operations relative to these new capital projects? And are we in a position yet to spend the capital necessary to support those projects? Another question was, what can we do quickly? What can we get out of the ground? What can we show progress with? What really reflects some of the effort that the Blue Ribbon Committee, and Steve's not here today, but I mean, I can tell you the Blue Ribbon Committee, there was a lot of discussion about what do we do in the community and how do we make an effort in the community as soon as possible without necessarily being able to address all the on-campus needs, but really extending JPS's services within the community. And that's where the medical home, the two medical home ideas came from. So that's just a little history as to where we ended up the way we did, until the Commissioners Court bangs the gavel and says, this is what we're doing, then all these are still, you know, I think recommendations. But what I'd like staff to do is take each one of those elements and walk us through on a couple of levels. First of all, let's understand the architectural component as opposed to the construction component. If there are plans that we have done in the past, what is our effort to integrate those plans? Do we own those plans? Are they someone else's plans? What are the issues regarding competitive bidding? We want to understand kind of everything there is to know about that process so that it's clear for us that we've got a transparent, you know, clear direction, and that the committee is on board with understanding that we've planned that correctly. And we may interrupt and ask questions as we go, but if you'll start off, I think we can, we'll fill in gaps.
Okay, so if we start with the two regional medical homes.
Okay.
The thought on the architect on that, we do own those plans. Corrigan did the work for us originally. They were selected based off an RFQ, you know, for the best qualifications for that. And so just because they've already done the work, they're familiar with the design, it is just more for us a financial reason that we looked at them, because we wouldn't have to pay somebody else all over again. And that's our prototype. When it comes to building that clinic, we would have to we'd have to issue an RFP like we do every single time, and we'd base our selection on best value, and we'd bring that back to the board as required, you know, by policy. We'd be sitting right here in front of y'all again. And, you know, whatever, we're here to serve, whatever the direction is on those regional medical homes, we are happy to do that.
And just let me ask you a question on the architect component. Those plans are done relative to Northeast. Is that's
Yes,
the
sir.
model? So if those plans are done, kind of contrast for us what it would look like to start from scratch versus what it looks like in terms of what we would be able to either add on or change regarding the current plans. And because I think we need to understand if there's a major difference between those two, or if it's really just incremental in terms of new costs that would be necessary to support two new medical homes. Give us some detail on that, please.
Okay, but this is what I would say on that. The change primarily to our prototype that we already have is the behavioral health component would be expanded in the new medical home. And if y'all remember, and I know all of you weren't on the planning committee at the time, but when we brought this forward to start with the design, that was done purposely to where we could expand on either end of that building with the shape. We could go out either way. And it would be easy because we're always growing. So that was one of the main things we did with that design, was it was laid out to be easy access for renovation and additions to that. Dollar-wise, gosh, it would just be, you know, a lot more money to pay somebody to start over. And the time. It's going to be a time component and a dollar component. And Lou, if you'd like to jump in, because Lou is working hard.
And Lou,
on
thank you. I
this.
know Lou's been working on this as well.
Sure. Currently, we're anticipating about a 40 to 45% in cost savings of design services. Is currently what we're anticipating by going with Corrigan again. Obviously, with when we're building on a new site, you know, we still had to do civil, we still had to do structure, and we still had to do construction administration and closeout. But as far as the internal components and the guts of the building, all the programming and planning that went into it, we get those economies of scale. And so that's why we proposed that last time.
And JPS owns those plans, correct?
Well, there's there's some intellectual property, legal counsel there. From an engineer's standpoint, there was their thoughts on paper. However, we do have some rights and some opportunities to leverage those.
We would not have to go pay them to do it all over again.
Not to pay them to do it all over again. Again, we're anticipating about a 40 to 45% cost savings in overall design services.
Okay.
What's the dollar amount of that?
Well, for Northeast Medical Home, the total design expenses was around 900,000. So is that 380?
45% is about 380, 370.
And that's per medical.
Okay.
So multiply that, and it adds up pretty quick.
What's your comparison?
I understand that fully. But you gotta, some kind of way, then we've got to go back and take a look at ourselves, because I might have missed that meeting, I don't know. But I don't recall us when we, okay, let me back up. I know that I was one of those who continually asked that we make sure that when we built Northeast, that it addressed future. Okay, that because when we did Southeast, it was too small when we finished. Okay, but I don't recall us putting in minutes saying this would be the future prototype. This would be for all other medical homes. Okay, it might be. We might have voted that. So when you take a look out in the community and they see us now voting to use this for other facilities, what are we saying to those contractors? Did we go behind the scenes and now we're okaying this particular? I'm dealing with just what it looks like, and when you're talking to individuals out there in the community, well, now you just zapped us out because you've already made up your mind on what you're going to do. So I don't know how we address that.
Yeah, it wouldn't, you said the word contractors. Contractors would still have to go through the process.
They're going to do a bid process.
I'm saying contract, but I'm talking about the whole process from the architect to the construction.
Okay.
But it really, if I hear what you're saying, Angie, and again, I don't remember whether it's a prototype. I know that building was designed. It does have, like I think you mentioned, it has the ability to be extended and enlarged. We don't even know where the next ones are going.
Right.
Correct.
But it sounds more of a financial question, Ralph. I don't recall we said who owns plans, who didn't own the plans. I hear us saying is, if we're happy with Northeast, and it is the prototype, and it works for the staff, and we think it is, we still have that option on the table to utilize that one.
Yes, sir.
But if we go someplace else and buy a different piece of property, and we want to hire a new architect, and we don't want the efficiency of saving the 45%, we would have had to hire another architect to do this one out here on its own. We can still go do that once we decide where these next medical homes are going. I mean, I think right now we're caught up with, we say 45%, but we don't know where, we're not changing the plans right now on that Northeast medical home in anticipation of where the next one's gonna be built. So everything's on hold right now. So the time to be asking these decisions is right now. It doesn't eliminate the fact that if we do, as a board, want to go out and hire another architect, we're not bound that architect is the only architect's gonna design everything for this institution, correct me, is that? So the options are on the table. I think the time to ask questions, Ralph, like this, they're good questions to ask at this point in time.
Let me ask, even if you are using the current architect's plans, we still have to pay them if we expand or if we do anything with it. You still have a cost there.
Yes, no question.
Yeah.
Okay, I just want to make sure. Yeah, okay, so you know, when we talk about the 45%, I'm thinking, well, you already got the plans now, why do you need to pay again? But even though we have it, we still have to pay.
Yeah, no, you're right, Dorothy.
The architectural services also includes your engineering, your MEPs, and those kind of things, which are, it's in the
Additional.
architect's scope, but another firm that the architect hires includes those into the plans.
I guess the question is, I don't think we're minimizing what we've done in Northeastern County. Seems to be working, the building's great, I'll ask the operational people, maybe there's issues I don't know about, but that seems to be
we got what we asked for. Now, we don't even know where we're gonna build next, who's gonna build it, and if we need to change architects, this board and planning committees, and those options are still on the table. And y'all haven't committed past what this board's approved.
That's
I think that's the point, yeah.
Let me say, and I'm not sitting here in disagreement of what we've done. I just want to make sure we got it clean.
Yeah, get that blackboard clean and so we can decide where we're gonna go next.
Right, so,
Okay.
So I have a question. On the Northeast campus, then, with the architecture plans that were had, was that a ground-up build, or was that a?
Ground
so-
up.
So then that's a clean slate, wherever we decide to put it. Does that give the flexibility if it's a building that we want to take over? Would we need another architect to do that? So if we decide to take over another piece of clinic or something that was.
Another piece of
Roger
property.
was saying, the architecture, their agreement has all the engineering work, so, we would need to, we'll still do soils testing, so the foundation and the civil, like the size and the orientation of the lot, the parking, we've got to redo that. We have to redo the structure, and then,
When you say redo the structure, what does that
What does that mean?
it's, the foundation design. Just the soil testing and the slab.
Geophysical and all
Concrete
that.
slab.
Oh, okay.
But the structural design of the building itself, the roof and the walls and all, that's already done. It's only for the foundation.
Okay.
Thank you.
Okay.
When we, and Roger will remember this, when we finally decided to move forward with Northeast, I know it was discussed in planning and at the board level that we wanted it to be a prototype, at least conceptually, so that we would have something functional that we could replicate, knowing that there would be pluses and minuses and changes. I don't think it was necessarily minuted action, but I think it was generally assumed that we would build ultimately that Northeast from the perspective of being able to replicate it. Is that right, Angie? Okay.
And if I can, Mr. Chairman, I think it's also, in addition to what we built, it had to be operational functional, and we had to spend time in there. And obviously, I'm gonna check the operations on, if it's working the way the architects designed it, and yet it's working the right way we want it to functionally, then I think that's a component, just because it's a pretty building and all that's great, but it's gotta be functional not only for coming and going and convenience, it's gotta be functional for the operational use intended that goes on the building. I think today the clarification is, I don't think we're currently bound, Ralph, I'm not putting more, but we're not bound to the existing architect of the Northeast Medical Home if there's decisions made to go build additional ones somewhere else. We can use that group, but we're not legally bound to use that if we want to go design another medical home. Is that? And, yeah, I mean, that's, y'all are the staff, so.
right,
Yeah.
but if I hear staff, and I would hate we would not go that route, but I hear staff said the prudent way is to use the present architect
Oh, yeah.
based on cost. Right,
Well,
so, hey,
And
yeah.
I can speak not only as a contractor, but also a patient at the Northeast Clinic. It is a very efficient
True.
use, and number one, it's a very nice clinic. But as someone who sits in that waiting corridor and see a lot of people go through those doors, it is a very efficient use of space, and I think a fine model. That could be either expanded or contracted, or however we needed to do it to whatever community it needs to be in. That base footprint is really a fantastic footprint. I have no idea about the operation. I guess I don't really care about that, but from a patient's side of view, it's very easy to identify if you're going to behavior, or if you're going to x-ray, if you're going to lab, or if you're going to dentistry. I think it's a great layout.
So does that clarify the position relative to the two clinics? Okay, then let's talk a little bit about the psych, this emergency psych center. And the question here is, when we initially started talking about this, there had been, you correct me if I'm wrong, there had been some discussion about a conceptual design that would allow us to begin looking at things like placement and traffic flow. It was not a contract to go build it. It was conceptual in nature to be able to give us a site look, location, access. Is that correct, Angie?
Yes, sir.
Okay.
Yes, sir. We were looking at, we know in the future we hope to build the behavioral health hospital, and where did it make the most sense to put the psych ED, because the 10th floor is not the optimal place
Right.
for it. And so we were looking at placement, what does it look like? That we would have to have an RFQ for an architect. We'd have to go out for that and bring that back to the planning committee, but that was, just such a big need that's what we were looking at.
So, am I hearing you correctly, that once we get that component, which we had actually contracted for before the bond election came about, that is something we discussed a year ago?
Well, that patient care center, that's the one you're thinking about that we're.
I thought we had also discussed the other
Well,
one,
we
I'm sorry.
talked about the psych ED, but we haven't made we haven't come back to
Okay.
y'all with anything on that one.
Okay, all
Patient
right.
care center, we did.
Okay, so the psych ED is still, at this point in time, that's a project that once the board approves and the commissioners court approves the money, that we will go out for an RFQ for an architect.
Yes, sir.
Okay. Is that clear? Everybody good with that? All right, so let's talk about the ambulatory center then.
Okay. The new
The
patient care center.
Yeah.
I'm
You
I'm
just keep
sorry.
changing
But
it.
we did come to y'all, and it has been probably last June that we came and talked about we went out for an RFQ. We had a short list of architects. We went through those architects. There was probably, I believe, a 7-member evaluation committee that included 4 executives and I think 3 people from my team. I believe that's correct. And we brought that forward. It was E4H was the architectural firm, and that was approved by the board. Now, we have not done anything. We haven't pushed forward with that. We're waiting for, more decisions. We need to know what to put in there. That's what we were looking at, the programming. What does need to go in there besides, the ambulatory surgery component? What makes the most sense? So that's the part we were currently wanting to look at.
So what's the scope as it is written today
Right.
for that contract?
The first phase, we just did the task order 1, and that is the programming is what we were starting with.
Okay.
But
For the overall contract is the entire, programming, planning, and design, and each stage would be brought back
Back,
to the board
yes.
for
Okay.
decision to move forward. There's currently only feasibility studies, kind of some demographics,
Okay.
and that sort of thing at this point, and particularly after Commissioner's Court, there hasn't been.
Stage informs the next stage, right?
Yes.
Correct.
And we bring that back to you at every stage.
At every stage,
Yes,
right?
sir.
Okay.
Yes, ma'am.
I have one question. When we were talking about the patient care center,
Yes, ma'am.
it was parking was included. What was the traffic flow? Is that the same contract?
Yes, ma'am. Yes, ma'am. That's
Okay,
it.
and so.
You're exactly right.
Because that was the one that we were, Zim was concerned about having enough parking, and you were gonna come back and provide us the best place to put it
That's
and all of that.
correct.
So
That's
that's what
correct.
you're working on now?
Yes, ma'am.
But it is a phased contract.
It is. With just a task order, and we, as we get approval, we'd move forward.
Okay, so that contract went through an RFQ. That was selected. And they are under contract. And when are you on hold right now? Or do you expect that to come forward to the planning committee with any recommendations regarding those phases?
Trent, we're working on that right now.
Okay,
I think by the time we meet again, we should have some more information for you.
okay.
So if that's okay,
So
we
from-
are
from-
actively working on it.
My question is it on hold or are y'all working on it?
We're working on it.
Okay, all right, so that was in process, right?
Okay, yeah.
Okay, so, parking garage. Tell me how that looks once we finally pull the trigger and say go.
Well, Lou, speak to that,
Lou?
because he loves parking.
I wouldn't say that. What the staff recommendation last month, the parking garage was included within the PEC and the behavioral health hospital. So all that was lumped into one component because we didn't want to build a parking garage that wasn't going to coincide with whatever ended up going on with the hospital. So that RFQ is on hold and will not move forward until approved. But the PEC, the parking garage, and the behavioral health hospital was the staff recommendation to move forward with an RFQ for architectural services.
So really no difference in what we have done on any other project?
No,
I mean,
sir.
it's preceded by an RFQ, the RFQ goes to committee, the committee makes recommendation to staff, staff comes back to planning, planning makes recommendation to the board, and the board awards the contract, right?
Yes, sir.
Which has been the standard process.
Same thing we do on
I think,
all of it, right?
Trent, part of the, and maybe some of my confusion and maybe a little bit of the disconnect is, and maybe when you're talking about planning and strategic plan is, it seems like we've passed the bond issue. We know what we want, what needs to be as part of the physical buildings. Okay, we don't know what happens in each of those buildings, but we know we need the PCC, and we know that we need the parking garage, and we know that we need the behavioral, and we know that there's a tower involved somewhere. I just know from speaking to Commissioner Fickus, is it just seems like, well, we're gonna put this here. It seems like there's no plan, there's no master plan as to what, say, in 15 years, the bond issue has been expended. It's halfway paid for, but what does the future of the campus itself look like? And I think that might be where the disconnect is. I mean, we've seen some maps, and it makes absolute sense that this building should go right here. But what happens to the old building that's next to it, or the old building we might need to buy across the street, or whatever else?
Andy, does that exist, a master plan, a master campus plan?
Not in its totality.
Yeah. I think that's one thing we're gonna hear on the 17th. I mean, the Boca Powell master plan study, this board has seen approved years back, because many on this board went all the United States before we got in the bond package. So that original, to say there was never a master plan, there was a master plan approved by the board. I think it needs updating now.
current one.
We didn't have $800 million, but yeah, it's time to update that master plan and decide what's gonna happen. I think that's where the Commissioners Court and this board, in collaboration, we didn't have the money, work together to get the money, and hopefully we'll work together to spend the money. So I think that's the next phase. And I think that's the piece that's missing.
And I think is going forward to our meeting on the 17th to tell the commissioners that, you know, a first step prior to hiring a program manager or to whatever else is we're gonna have some consultants come down and say, this is really the way your campus should operate. I think that would go very far in assuring them that we're not just, we've got $800 million and we're just throwing buildings where they seem to fit.
PEC that they didn't know about. What do you mean?
I would agree with Roger, because one of my concerns is, again, is that we go into this meeting with the Commissioners Court, and they already have somewhat their thought process of what they envision taking place. But you've appointed us as a board to lead, but what are we gonna lead with? We don't have a package. And that's what really my concern is, you know, when we talk about program and construction and all, you know, it's Trent listed those items a second ago. I would hate really for us to go into that meeting saying these are our items, as opposed to, hey, this is our program. This is where we see this going, this going, this going. And especially when we talk about, and I said this before, all of the new trends and new things that are happening in the healthcare industry. We talk about the medical homes, and you got CVS. Yeah, CVS that's talking about doing their own clinics. I mean, that would impact where we put the medical homes, basically, you know. So I would just hope that we would have, I don't know, we can't fast track that, but we have something to say to them. Because what I don't want, what I'm hoping not to happen is, yeah, we're on camera, aren't we? Okay, but that we become just.
Mr. Brooks, turn it off.
Yeah. That I just don't want us to become the puppet. And that they are making decisions politically, but we're making decisions community-wise. And I think we just got to be careful of that. And I think somewhere we got to say, Commissioners Court, you appointed us, let us do that. Let us, you know, even if we don't have it going in, to say we are working to have that.
Well, I can tell you that from our discussions, it was very clear to me that the Commissioners Court wanted to keep the board very integral in this process, and that they were going to listen to board input and rely on board input when it came to final decisions. I still think there's questions about the details of how each component of this gets approved and when. I think that's still out there, but I've never had the feeling that the commissioners were in any way trying to supplant the board when it came to exactly what we're talking about.
Right.
So to that end, Angie, I'm gonna put you on the spot here, and I won't hold you to it, even though you're on television, there's 1 million people watching. If we were to, at this point in time, try to wrap up a scope that sort of defined a campus master plan or a new plan that would encompass the phasing and everything you've heard today, how long would it take to put such a scope together, and what would we be expecting in terms of an RFQ? Because I would not be surprised if after this, we're not asked to prepare such a scope and be in a position to be ready to advise the board on recommending that. So what does that look like in your opinion?
Couple
And Bill,
hours.
Lou, Bill or Lou, weigh
No,
in too.
you know,
I mean, not just you
seriously,
on the spot.
Mr. Chairman, if you told us when you wanted it, we would have something. But truly, if we've never done a bond package, obviously nobody at this side of the table has. So there probably is an opportunity for us to go out and find as Roger said, a consultant to help us put that together.
Okay.
You know, I want to have a complete plan for y'all,
Sure.
something to look at that you can approve, and I know Lou does as well.
Okay.
But it's certainly, we're not going to be able to have it together by the 17th.
No, and I wasn't implying that. More along the lines of if it comes out on the 17th, that the hospital district should pursue such a course.
Right. I'm
How would it-
thinking
how would it look?
90 days, 90,
Wow.
90, maybe
That's-
120.
that's fast.
I think we can start, get something together for y'all to look at. It wouldn't have all the financials, everything. It wouldn't be the
Yeah.
whole big package. Is that what you're
But
looking for?
before we could use that to go out there and essentially start construction of a project, we're talking longer than 90 days.
Well, yeah, I thought you just wanted our little program of what we're doing.
Yeah.
What the RFQ would look like.
Yeah.
That's what I was under.
Okay, so it's a major effort.
And if you're gonna build a brand new RFQ, and I go back to the previous consultants, which we paid a fortune to, and ask them to update, there's two separate entities here.
Well, and
The previous boards that committed to master plans, we can name all those companies, there's been, the commissioners know exactly how many dollars were spent. We gonna go back there and bring that forward, or we gonna throw all that and start over? I think that's some of those directions we're gonna need some input.
It's a very legitimate question, and to what extent we utilize existing plans, and I think staff will be relied heavily on this. The board and I think the Commissioners Court both will say, okay, Robert and staff, Boca Powell was X, Blue Cottage was Y. It's been 8, 9 years. From a staff perspective, how much of this is usable versus how much is not? Because there may be, even then, a more efficient path rather than just starting over. I can't imagine that we would start over. But from a timing perspective, I'm still trying to keep us where we all talked about wanting to be, and that's, not go down the road 10 years before we have something under construction. So I think that's something staff should probably prepare for, is discussion about what components are usable and should be updated, what components should we throw out and start over on. But I think ultimately it's going to come up to you all to tell us what that scope needs to look like, and this group's then going to have to make a decision on what that RFQ process looks like and the timing and cost and everything else, right?
Yes, sir.
Yeah, because, as I'm sitting here thinking, the Boca Powell and the Blue Cottage, I can't remember if we gave them the charge to look at this because we're looking at bond as opposed to looking at this to look at it just a master plan.
I think this was a master plan, if I can recall.
Right.
There's a lot of work done before I came on board, but I think the real question is healthcare, you brought it up, is healthcare changed so much that their master plan is an antiquated way of looking at things? It was a master plan, and when you look at what was spent, it was a phenomenal amount of dollars spent, and a lot of hours went into it. I'm just saying is, we probably need to see, is there something there that could be used? If not, if we have to go out for brand new, you gotta remember something, we don't have $800 million sitting in the bank.
Right.
These are bond deals, we're not
Right.
paying interest. I mean, I think the issue is we gotta get the services and get these facilities so we can better serve our patients. I think that's the reason behind it. I think the question as to where it goes and how it goes and those costs, do we go back and look, like you say, say, Trent, Blue Cottage, my gosh, they were in here for, what, I bet.
Long time.
2 years. You've a chair, you're a chair, there's a chair sitting over. There's been 2 or 3 chairs. We went through a lot of discussions through all over the country, looking at their hospitals and looking at things. A lot of work was spent. If we need to put that back over here, start over, I'm certainly for that. But I think somebody's gonna ask us, there was a lot of dollars and times expended in those deals, so.
If you take all of those, the Blue Cottage, and then you took the Blue Ribbon Panel, there are 4 or 5 components of that followed through.
Right.
I mean, the master plan followed through, and I think if you look at that, all I'm saying is that once you take those out, what will that campus look like?
Right.
You've already done the oncology piece. It's already plopped somewhere else. And now we're saying on the behavior, which I'm not sure if it's one major here or where, but that was something that we'd have to discuss. But you're talking about the patient care center was in all 3 of them.
That's right. And Trent, you
And
know,
the CHCs were there. So
Right now,
you're
it's the
talking
patient
about
care
taking those pieces and saying where would they fit, and what is the timeline of something like that? And you did some cost estimates and operational, you ain't gonna put them up, but a couple of them the first year anyway.
in fact, Trent, if you recall, you served on the Citizens Blue Ribbon Committee, and one of their charges they looked at what master plans had been done. They had to know what kind of dollars to go out for. They just didn't pull the money out of the air. So there was a framework of some master plan, or we'd have never got through the Citizens Blue Ribbon Committee. They wouldn't know what they needed. So I think
the
we're
only
headed.
exception to that was even the Citizens Blue Ribbon Committee had no inkling where the 2 clinics might go.
Where they go, that's right. Now we're down to where's things going.
I find it interesting because Blue Cottage and Broadus did the master plans. We get on bus and planes and fly around the country. We left thinking one thing, we came back, Dorothy wanted an ambulatory center.
That's right. And Dorothy's gonna get one. And let me make one statement for those new to the board. Boca Powell, yes, Don Powell out of Dallas, Texas, I don't know him. He's the wealthy Powell. I have no relationship with Don Powell and Boca Powell. So I want y'all to know that, so. Anyway.
Okay, so, committee, does that put you all in a good position of knowing where we stand and where we are relative to preparation for the 17th?
I think it's a good exercise, Trent, I really do.
All right.
Ralph, is a good question.
Anybody have any more questions? You good, Chuck?
I'm good. Good.
I'm good.
Okay.
Sorry, Angie, you got a lot of stuff to do.
Anything else from staff that you'd planned on telling us that you hadn't told us?
No, sir, we're good.
Good deal.
We appreciate it very much. We have to be led through this step by step because it's complex. It's got a lot of money and a lot of time, and there's a lot of eyes watching. So we earnestly want to do it right. All of us do. So I appreciate it.
So the meeting on the 17th is downtown?
Yes.
Yes,
Yes.
that's my understanding.
It is. It's posted, yeah, it's downtown.
All right. Is there anything else to come before the committee then today? I'm so happy I'm gonna get to watch my son's football game. 100 degrees outside. All right, then hearing no further business, we'll stand adjourned at 4:13 p.m. Thank you all.
Good.